Hi, my name is Sidra Ismail. I'm going to discuss different types of patient interactions in the ER, and also I'm going to kind of demonstrate different types of patients that come into the ER and how one interacts with it. I have a special guest in this video today to demonstrate those patients. All right, number one. Hi, how are you doing today?
Oh, not good at all.
What is your complaint today?
I think I broke my rib or something. It hurts really bad.
Okay.
I need something for it.
All right. Anywhere else?
There, and it's traveling up my back to my shoulder. It's really bad. I need to be seen.
If I ask you, 1 being the lowest amount to 10 being the worst pain in your life you've ever experienced, what would you consider this pain?
It's definitely a 10. I really need to see somebody.
Okay.
It's really bad. It's really bad.
Okay, we'll get you roomed as soon as we can. Can I take your blood pressure?
Do we have to do this? I really need to be seen.
Okay. What medication do you usually take for your pain?
I was given Dilaudid previously, but I'm out. I need more for this. This is really bad. Oh.
Okay, sir, we'll get you the room as soon as we can. This is one of the common interactions with the patients who come in for seeking pain medication. They already know what's the right things to say, where the pain is located, exactly where, and how much pain they are in. Also, most people are well aware of the medications, so say Dilaudid is one of the favorite medication. I don't know why, but patients always request Dilaudid, morphine. I had a patient once who came in for a headache and was like, "Oh, I have to have morphine. There's no other medication that works for me." The PA suggested Motrin or like a higher dose of Motrin, and she was like, "Nope, I can't do it. If you can't help me, I'm leaving." But second type of patients that we get in the ER are actually truly in pain, and they truly do need medication. But how can one assess that? This is a second example. Hi, sir. How are you today?
Okay.
Okay. What's going on today? What brings you to the ER?
Some pain in my shoulder.
Okay. Did you hurt, strain?
I did something weird with it, and it's been hurting ever since when I was working out.
Okay. If I tell you your pain scale, rank your pain from 1 to 10, 1 being the least pain to 10 being the worst pain in your entire life, what would you consider this?
8.
8. Okay. Have you taken any medication for it?
I've been taking Motrin.
Okay. Anything else that helps you with the pain?
Just that, and I tried to ice it, but it doesn't seem to be getting any better.
Okay, we'll get you roomed as soon as possible. This is second interaction. In this interaction, you can see the patient is a lot more relaxed, and he thinks about his pain before he describes the pain to the nurse. In most cases, if it's a chronic pain, patient come out directly and just request pain medication instead of even trying different type of interaction. In my paper, I talked about different examples where when I interviewed a doctor, and he said that a patient came in with a broken foot, and she was requesting pain meds. So the nurse went up to the doctor and she was like, "Can I give some pain meds to this?" Or dislocated his foot, and the doctor was like, "It doesn't help." And the nurse was like, "What do you mean the pain medication doesn't help?" The doctor was like, "No, until that foot is in place, the medication is not going to help the patient." A lot of doctors nowadays are trying to get away from overprescribing medication, but at the same time, there is no agreement between the doctors. So if, say, one doctor says, "Oh, so you can give them, say 0.1 milligram of Dilaudid," and the other doctor says, "No Dilaudid for this patient." There's no agreement within the hospital or facility, and that's a huge problem. One of the solutions that I suggested in my paper was talking about how the facilities and the doctor needs to be in the same page about prescribing medication. Another solution I discussed was the proper follow-up process, such as that now when the patient comes to the ER after they're discharged with medication. In about a week or so, the nurse reaches out to the patient, asks them how they're doing. The patient either says, "Oh, I need more refills," or, "I'm doing okay." At that point, the nurse doesn't take any other steps to follow up with the patient to see what they can do. They just try to kind of refer the patient back to their primary care physician. But if the patient doesn't have a primary care physician, they end up right back in the ER requesting more medication. So in cases like that, I felt like a better process could be put in place, such as assigning a nurse to a patient's case, having the nurse visit the patient at home and assessing the progress. And if the patient is not available, because I'm sure everybody works, most of us have jobs and stuff like that, so the nurse can schedule another time for an office visit for a patient instead of just providing a blanket information for discharge and saying, okay, just follow up with your doctor. I think that that's the best solution that you can come up with, which will provide patients with more confidence in following up with doctors after the nurse visit. But a standard discharge instruction doesn't provide them any information. Just say, okay, well, we did whatever we could. Now let your doctor handle it. But most patients with Medicaid and Medicare and other governmental insurance, it's hard for patients to get an appointment. I have so many patients who come to the ER and they just come to the ER only because they can't get an appointment with their doctor. For a short period of time, my mother had Medicaid, and she was assigned to a certain doctor, and every time we would go there, we would have to wait anywhere from 3 to 4 hours just to be seen. And my mother doesn't drive, so obviously I used to drive her, and I had work at the same time. I had to take my mother to the doctor. It was a nightmare. So keeping that in mind, it's not always the patient's fault, and it's not always the hospital's fault, or there's a lot of mitigating factors between the initial patient visit versus the initial patient visits and then follow-up visits. Thank you so much.